Hello, my name is Jason Busse. I am one of the co-principal investigators of the trial to reevaluate ultrasound in the study of tibial fracture healing, the acronym for which is TRUST. Tibial fractures are the most common long bone fractures, and complications following tibial fractures are common, including non-union, which affects between 15 to 45% of all tibial fractures. In an attempt to accelerate healing and reduce adverse events such as non-union, certain modalities have been suggested, including low-intensity pulsed ultrasound, which is a form of bone stimulation that has been purported to promote fracture healing. There have been some small trials that have shown favorable results in terms of accelerating radiographic healing, notably trials by Heckman et al. In 1994 and Leung et al. In 2004. There have also, however, been some studies which have suggested that low-intensity pulsed ultrasound may not be effective in accelerating radiographic fracture healing, notably a trial by Imami et al. In 1999. Now, the number of trials available to inform the effectiveness of low-intensity pulsed ultrasound, or as it's known in abbreviated form, LIPUS, are limited because of methodologic issues such as loss to follow-up, lack of blinding of key members, and in all cases, small sample size, and in almost all cases, lack of what we would call patient-important outcomes. Patients are unlikely to be concerned about how their X-ray looks. They are much more likely to be concerned about their ability to return to function, return to work, return to weight bearing, return to leisure activities. In order to try to resolve the controversy surrounding the use of LIPUS, we designed and carried out a large randomized controlled trial across a number of orthopedic trauma centers. We had a primary outcome, a co-primary outcome of short form 36 physical component summary score, which is a validated measure of physical functioning. And our other co-primary outcome measure was radiographic healing, which we assessed using RUST scores. And our population of interest were tibial shaft fractures that were managed with intramedullary nailing. We took great efforts in this study to blind the healthcare providers, the patients, the data collectors, the outcome assessors, and even the analysts that were doing the statistical calculations for the trial. They simply analyzed the groups as Group A and Group B without knowing what the actual allocation was until all analysis was done. The eligibility criteria were skeletally mature adults with open or closed tibial fractures that were managed with an intramedullary nail, and the follow-up period was 1 year. We did exclude Gastillo 3C injuries, segmental fractures, fractures that extended into the joint, fractures that included circumferential tissue injury that precluded placement of the ultrasound device, spiral fractures that exceeded 3 centimeters, or open fractures in cases in which debridement occurred greater than 24 hours after the fracture itself. We had identical appearing active and sham devices. They were both prepared by the industry manufacturer. They were identical in every way except one device had the ability to produce active ultrasound and the other produced no signal at all. We did stratify patients by open or closed fractures to ensure that we had an equal representation of both in both the treatment and the sham group, because we believe that the prognosis for healing would be quite different, whether they had an open or a closed fracture. The intervention, as I mentioned, was low-intensity pulsed ultrasound, or LIPUS, and this was administered by patients in an outpatient setting, and they were instructed to do so for 20 minutes per day. While they were in hospital, they were each given an instruction about how to use the device in a hospital setting, and then once they were discharged, they were expected to continue with that use on a daily basis until they were informed that their fracture had demonstrated radiographic healing at all 4 cortices, or until 1 year had passed. We had a number of follow-up time points to capture their progress in terms of functional recovery and radiographic healing. Those time points were at 2 weeks, 12 weeks, 18 weeks, 26 weeks, 38 weeks, and then finally at 1 year. Radiographs were taken at each of these time points until the attending surgeon determined that they had shown bridging at all 4 cortices. In terms of the sample size for the trial, we powered it to detect a difference of 4 points on the short form 36 physical component summary score, 4 point having evidence as being the smallest difference that patients can detect, or the minimally important difference. And in order to meet this power requirement, we enrolled 250 patients per study arm. We had secondary outcomes that we explored as well. This included the Health Utilities Index, when patients reported they were back to work, when patients reported they had returned to 80% of their pre-injury functioning, when patients reported they had returned to their leisure activities without limitations, and when patients were fully weight-bearing. The radiographic evaluation was done using the Radiographic Union Score in Tibial Fractures, or RUST, which is a validated measure, and the outcome of radiographic healing was adjudicated centrally by a group of surgeons that were not otherwise involved in the trial and were blinded at all times to allocation of participants. We used intent to treat to guide the statistical analysis plan, and we did adjust our analyses for factors including age, smoking status, site of injury, fracture pattern, and degree of fracture gap. We also conducted sensitivity analysis that incorporated imputation for missing data. Our analysis considered one subgroup analysis, and that would be open versus closed fractures, under the assumption that open fractures would show a greater response to the use of low-intensity pulsed ultrasound. We also measured compliance, and the way that we did that is we looked at the number of days that patients administered at least 18 minutes of lipus over the total number of days that they were supposed to be administering lipus. We enrolled a total of 501 patients into the TRUST trial. This included 345 men and 156 women. Average age of enrolled patients was 38 years. They included 387 closed tibial shaft fractures and 114 open fractures. 165 patients endorsed that they were currently smokers. And in terms of the type of fracture, the majority of the closed fractures were Tichern grade 0 or 1. And we did have an analysis plan to do an interim analysis when 300 patients had been fully followed to 1 year. However, the industry sponsor conducted an earlier unplanned interim analysis of the blinded study data and on the basis of futility opted to stop the trial early. Now, we had 424 out of the 501 patients that were available to calculate compliance. Some patients didn't return the study device. There were a few cases in which the study device did not record compliance properly. But out of the data that we did have, we found that 45% of patients had administered more than 75% of all planned administration, so the daily use of lipus for at least 18 minutes. We found that another 28% had used the device between 50 and 75% of all the time that they should have. So in terms of looking at the proportion of patients that administered lipus for at least 50% of the recommended administrations, we had about 3 out of 4 patients that did meet that threshold. So compliance was reasonable, and given what we know about the challenges in getting patients to administer an outpatient device on a daily basis for 18 minutes, probably very reflective of what we can expect. The results were, we found no statistically significant difference in SF36 PCS scores between treatment groups. The difference between groups was 0.55 points. And as you recall, the minimally important difference is 4 points. So This was a very, very small difference and it was not significant. For the Health Utility Index, the difference between groups was also not statistically significant. The mean difference was 0.01 points, and the minimally important difference for this instrument is 0.03 points. When we looked at radiographic healing, we again saw no difference in healing over time between the group that was given the active device or the group that was given the sham device. In terms of our secondary outcomes, we saw no significant difference either in rates of return to work, rates of return to leisure activities, rates of return to pre-injury functioning, or time to return to full weight bearing. In terms of adverse events, we saw no differences either in rates of secondary operations or non-unions between the group that was treated with active lipus or the group that received the sham device. In conclusion, the TRUST trial demonstrated no differences whether patients were treated with an active device or a sham device in return to function as measured by the SF30 physical component summary scores or in direct measures of return to function or time to weight bearing, and no difference in time to radiographic healing. There were some limitations associated with the study, particularly the decision by the industry sponsor to stop the trial early resulted in 73 patients that we had enrolled that were not fully followed up, and our compliance rate was moderate, where we had, again, about 75% of our patients showed greater than 50% compliance, and 45% showing about greater than 75% compliance.